identifying and investigating immune deficiency. Rossa, over to you.
Okay, thanks, Atul. Can you hear me?
Yeah.
I can't believe you set me up like that. Now let me share my screen and give you my very, very normal slides. Hang on, this should work. Okay, so have you got my slides up now?
Yeah.
Great, cool. Okay, yeah, so thank you for the invite to speak. I'm going to do a very practical talk this morning, talking about an approach to identifying and investigating immune deficiency. It's based really on an ERS chapter that will come out in the handbook once all this madness is over. It's really about trying to pick up the children who we see who get referred up by GPs. In the olden days, 3 weeks ago when outpatients existed, medicine BC, and how to pick out the ones that get referred up either by general practitioners or by the local paediatricians to try and pick out who's actually the ones that we need to start thinking about their immune system. So this is the stuff that confused me, certainly when I was a paediatric A&E SHO and then beginning my respiratory career. This is the things I needed to have in my head, because it was never very clear what the consensus was as to when has a cough gone on too long, or how many infections is too many. And my difficulty was trying to tease out, just like anybody else essentially, that one rare child from the group who are going to be turning up in the emergency department. And then people would say, do an immune screen. I'd say yes. And someone would tell me what the immune screen was. And I'd say, okay. And I would request those bloods. But it took a little while for things to drop for me as to what an immune screen means, what it's based on, the underlying, essentially the physiology, pathophysiology. And then another skill, as I was moving through, was trying to work out who needs to be referred and who doesn't, because the immunologists are rapidly going to get quite upset if I started sending them everybody I wasn't quite sure about. So what I wanted was some rules. Can I just say quickly, I'm not Andy Bush, and this is not a photo of my child, although she does look quite similar to my daughter. So listen, the way that we need to think about this is to go back to the basics and think about two real concepts in terms of the immune system, the innate immunity and adaptive immunity. Those of you who've seen me talk about pollution in the past will be aware that I'm obsessed with the first barrier to any pathogen or pollution molecule is the hair in my nose. My nose is also lined by mucus, thankfully not too much, which is why I'm still able to come here and do the talk. And then you've got your cilia and the various innate proteins that are involved in recognizing pathogens. So mannose binding lectin and the capsular polysaccharide of pneumococcus, which we all call CRP, are fairly well conserved throughout evolution. And plants have MBL, and they use that to label bacteria to try and remove them. And then there's complement. And then we have the adaptive immunity, which is more that we seem to look at when we're doing an immune screen itself. Again, the basics are, and apologies if this is old hat to you, but if the second year of medical school is a little bit distant, I'll just go over it again briefly. Pathogens turn up, they get into your upper and lower airway, and they're met by an antigen-presenting cell, which is either a dendritic cell or a macrophage. I've got a nice picture of a dendritic cell here, named because all those dendrites are sort of branching out. And they put feelers up through the respiratory epithelium, and they probably have a bit of their cytoplasm and external cell receptors sitting in the epithelium itself, constantly sampling the airway and seeing what's coming in. They will then phagocytose various pathogens and display them on their cell surface using HLA2, MHC2, sorry. They will then activate T cells that are around and about. And then the T cells will direct their subsequent responses. So they'll either get B cells to make antibody, they'll get the phagocytic lymphocytes, the white blood cells that like to eat stuff to get rid of it, neutrophils and macrophages, to turn up and start doing their job. Or on their own, those T cells can directly program a cell death, direct cell mediated apoptosis. So they will say to a respiratory epithelial cell, you are infected with coronavirus, die now before it spreads anywhere. And then that cell will do that, it will explode, it will leak wet goo from its cytoplasm everywhere and will give you a watery cough. So that's essentially the outline of this talk, is where those systems don't work, we will end up seeing disease. And a lot of these will present to respiratory doctors or to GPs or to paediatricians in A&E and in DGHs, and you've got to try and pick these up. So if your T cells aren't getting your B cells to work, or for whatever reason the B cells aren't working, you're going to have little antibody or no antibody. if your neutrophils and your macrophages aren't doing the job, then they don't work, and you won't be able to phagocytose the kind of pathogens, usually bacteria and fungi, that those cells are working against all the time while we're thinking in the background. And if your direct cell-mediated apoptosis isn't working, or your T cells or NK cells or combinations of those aren't working at all, you're going to end up with fairly severe combined immune deficiencies, and we'll have a look at those in a minute. But the first thing is, when has a cough gone on for too long? Like many people, if I've got a difficult respiratory question, I just put Bush A into PubMed, and this pops up. So Andy, with a colleague, Dr. De Benedictis in Italy, has written a lovely recurrent lower respiratory tract infections in children practice article for the BMJ. Unfortunately, as I was beginning to read this, it starts with, there is no consensus on how many episodes of lower respiratory tract infection are too many. And I'm looking at this, and Andy, if you're out there, that first paragraph did not help me with this talk, but anyhow. So thankfully then, consensus begins to emerge through this article. And these are essentially the basic rules as they're laid out. Have to impress upon you here that these are based on healthy children. This is not an ex-premature child who's got fallen cerebral palsy and an abnormal swallow. We're talking about kids who turn up in GP practice or A&E, and you can be reassuring if they've had a common cold symptom that's lasting up to 15 days, or a cough lasting up to 25 days. So that's typically going to be a runny nose, upper respiratory tract infection, maybe a bit of a chesty cough with maybe some post-viral dry cough, you know, early hours in the morning. We've all heard our kids doing it, and if you haven't had kids yet, or you're not going to have kids, trust me, they will do that. You'll wake up at 5 a.m. hearing the child cough, and you think, am I going to get bashed by my wife because she's going to tell me off for the fact the child's still coughing and it's kind of my job, but she isn't bothered either, so that's okay. Recurrent acute coughs with a week symptom-free in between are probably recurrent viral colds. And again, anecdotorama, having small children. I remember as an SHO being flummoxed by this, and the guy who's now a paediatric consultant at St Mary's, Bob Claver, was my reg at the time. He said, look, Rossa, my kids have got train tracks coming out of their noses from September through to March every year. I didn't believe him, but he was absolutely right. And my kids have done exactly the same. So literally there'll be cough, cold, runny nose for a week, 10 days. It goes away for like a week, and then it's back again, the next one, the next one, the next one. And that's part of them building up their healthy immune system. Probably sharing lots of different types of coronaviruses between themselves, but that's a different talk for later on today. And then the rules when it's not okay, and you've got to get something done. If you've got 3 or more in a 12-month period, in a year, lower respiratory tract infections, that can be bronchiolitis, it can be bronchitis, it could be pneumonia. That needs to get your red flags up. Or if there's a daily, every single day, wet sounding cough for 4 or more weeks. So 28 days of a wet cough every day with no wellness in between has got to get you thinking. Now, I work in an ivory tower and have done for a long time, and you've got to jump through quite a few hoops before you end up in our clinic. So I thought the best thing to do with this article is to send it to my sister. She's a GP in Southwest London. She's got 3 children. She read it and she said to me, no, this is sensible. I can work with this as a GP. So I got that's the ultimate stamp of honor in my family. If my sister says it's okay, then you know it's going to be fine. And she's younger than me, and I'm still listening to her. These are the red flags from the article. So if there's a recurrent or prolonged history, as we've just said, you know, multiple episodes, 3 or more of unusual lower tract infections, or they're going on for too long with 4-week cough. Obviously, children with clubbing are going to get people's eyebrows raised. If you've got secretions, if you're little and you're not a sputum producer, but you're getting secretions coming up, that's an unusual thing and needs to be taken seriously. Hearing crackles, particularly dry crackles in a child's chest, that would be an odd thing that begins to make you think about rare, weird, and wonderful things like interstitial lung diseases. Picking up unusual pathogens if you're doing cough swabs or sputums. So you don't want to see Staph aureus. You don't want to see Pseudomonas aeruginosa coming up on swabs. I mean, it can happen, and you will. You know, I know a few children who've been extensively investigated for having Pseudomonas aeruginosa, and yet you can't find anything that's wrong with them, and it might just be bad luck, but it's an unusual sign, and you've got to take that seriously. Persistent or recurrent chest X-ray changes are unusual, especially. It's quite hard to convince paediatricians to do lots of chest X-rays in kids these days. It's not the dogma. So if children are getting lots of chest X-rays and you're seeing chest X-ray changes on them, I think that should be taken seriously. And then the differential for what the causes are of these coughs really is built on the history and what's going on. So, you know, most of these things will not be rare immune deficiencies. You know, the rare immune deficiencies are the sort of 1 in about 10,000, 50,000 types of things. And I was working out this morning while I was on my bike on the way in that I think a GP, we probably see about 6,000 patients a year are going to have to work for 5–10 years before they might even meet one of these things. But the common stuff is much more likely. Persistent bacterial bronchitis. Is this story actually going to be pertussis? Is it TB? Got to think about things like foreign bodies. That's all in the history. Asthma, bronchiectasis or chronic suppurative lung diseases, reflux and reflux aspiration, congenital cardiac and lung diseases. These are all much more common than the tiny thing that I've put in tiny writing that everyone's going to hopefully slightly peer at their laptop screen and try and read, which is why I've put it in very small text, some rare immune deficiency. So I'll take you through an anecdote of a patient who I looked after last year, 3-year-old, born in the UK, so we can be relatively certain that they don't have cystic fibrosis as long as you check with the parents that they've had their newborn Hilbert screening done. They're referred by the local DGH paediatrician as, could this be asthma? Mum walked into the room and she said to me, oh, doctor, we've been in and out of hospital since 7 months of age with colds that just get straight onto the chest. As opposed to saying it was, coughs and colds and the upper stuff all the time. She really did describe things being very chesty. And the nice question I like to ask, which I'm sure I nicked from somebody cleverer and better at medicine than me, was to say, if you're holding them, can you feel them bubbling? Can you feel wheezes and rattles lower down? The child was environmental tobacco smoke exposed, had been started on a moderate dose of Clendil, beclomethasone, was using salbutamol appropriately with spacer, and they had been started by the DGH paediatrician on prophylactic azithromycin in view of the recurrent infections. These are the chest x-rays. These are taken 3 months apart. The one on the right is when she was unwell and turned up in A&E, which is why it's an AP supine. You can see some right middle zone changes there. Chris did teach me how to use the mouse and I've forgotten about it, but believe me, the right middle zone looks a bit hazy. And then the x-ray that's on the left of the screen was taken when she was well and came to our clinic about 3 months later. Well, as in she wasn't in resus getting an x-ray done because she was hypoxic, but she was coughing then with a wet cough and right-sided changes still. So the differential here, as I've given to you in a couple of slides before, is this, and that absolutely drives what you're going to do in terms of investigations. Is this something rare and funny, or is it something a bit more obvious? So it could be persistent bacterial bronchitis, and the way to tease that out as well as from the history is doing a trial of treatment or doing a bronchoscopy, or doing a trial of treatment and then a bronchoscopy if things recur, because it can be, in fact, it's common to be recurrent. Is this pertussis? That's really on the history, and if you're suspicious enough, you can do serology, although that doesn't have fantastic sensitivity and specificity. You can do PCR, but again, you need to try and catch that early on when people are still shedding the pertussis. Is it TB? Well, again, a lot of that's in the history and risk factors. You can do a MAN2, an interferon gamma release assay, so an LE spot or a TB spot, and chest x-ray. Is it a foreign body? That's all on the history, and that didn't fit here at all. Is it asthma? Is it viral-induced wheeze? So again, that's all in the history, and then a trial of treatment. You give your 6 weeks of Clendil and you see if you see a difference in terms of symptoms, and that was essentially what had been done here and hadn't worked. So that was very useful in terms of the history going forward. Could it be chronic suppurative lung disease or underlying bronchiectasis? You'd be unlucky in a 3-year-old. That's then on the history. If the chest x-rays are suspicious and things aren't getting better, then you might think about doing a CT, but that didn't feel the right thing to do here. And then could it be reflux or reflux aspiration? So is there stuff coming from the stomach up and then getting into the lungs, or is the child aspirating from the top down? Again, that's on the history. Is there coughing and choking and spluttering when they're drinking? And then if you've got the kit in your hospital, pH study and PID study, support from speech and language therapists who may or may not want to do a video fluoroscopy. And again, small text down the bottom, doesn't feel so likely to be an immune deficiency here. So this is what ended up happening. She had a video fluoroscopy because there was some suggestion in history that the swallow might be abnormal. That was normal, and she had a trial of treatment. That was a little bit successful, but not completely. And when she came back to clinic, we decided we'd go for the bronchoscopy. So when she had the lavage, there were thin yellow secretions both sides, thin, easily aspirated at the scope. Neutrophilia on that lavage and green Haemophilus influenzae. Her sweat test was normal. As I say, she had a VF. pH was normal that we did at the same time as the bronch. And the immune screen was normal. So her diagnosis was persistent bacterial bronchitis. Phoned her up after 4 weeks of augmentin, things were much better, came back to clinic, did a chest x-ray, and the chest x-ray had cleared up completely, stopped her azithromycin, and she's now well. So that doesn't fit with my talk at all. That's not a child who's got an immune deficiency, but it takes you through the initial thinking process of the stuff that you can tease out. My next case is a 6-month-old boy. He had a label on his transfer to us as recurrent bronchiolitis, and it was an inpatient transfer because he couldn't wean oxygen. So he picked up bronchiolitis and he just couldn't shake it off. They couldn't get his oxygen down, and the chest X-ray looked a bit grey. And the referral from the local hospital was, could this be interstitial lung disease? Of note, he also had failure to thrive, which is how patients with ILD can present, although maybe a little bit older. And his echo was normal. This is not his actual chest X-ray, but it is one that's representative, and I hope that you're convinced that it's just sort of too grey and too hazy out to the edges. So in view of this, he had a CT scan. This was a CT, which wasn't really felt to look like interstitial lung disease at all. This ground glass changes, but there's a little bit of septal thickening and it's a bit patchy. So we went down our list that we've just gone through. It doesn't sound like PPB, doesn't sound like pertussis TB, it doesn't sound like a foreign body, you'd have picked that up ages ago, far too young for asthma, bronchiectasis, well, he's had his CT scan, doesn't feel like reflux and reflux aspiration. So now we're in the tiny text down at the bottom. Is it a rare immune deficiency? And this guy needs some immune deficiency blood. So going back to the basics, we know we've talked about innate, ciliary proteins, barriers, and we've talked about adaptive. So that drives what the immune screen is going to involve. If you want to know if your barrier is functioning properly, you need to know what the epithelial mucus layer is doing, and you want to know what the cilia are doing. So you need a sweat test to rule out CF. You need to screen with nasal nitric oxide, but he's a bit young for that. And if you're in a centre or nearby a centre that can do it, you can have a relatively low threshold for doing brushings if the history fits. You need to do an MBL, and you can think about complement levels. And then for the adaptive side, are there enough white blood cells floating around inside this child's blood? And you can drill into that a bit further on an initial immune screen or a secondary one by doing lymphocyte subsets. That's debated as to whether you should do that first line. Do the T cells work? So this is your chance to do your protein and your carbohydrate vaccine responses. I always wondered why we just pull out, you do tetanus and pneumococcus, and the reason is that tetanus is a protein, and the pneumococcus vaccine is a sugar moiety, that's the labels on the outside of the bacteria. So if you know your T cells are able to mount normal responses by producing B cells that will give you antibody against tetanus and pneumococcus, you know they can recognize multiple types of epitopes, and you can think about a phytohemagglutinin assay. Are the B cells working in this child? What are the immunoglobulin levels? Are they there? Can you do IgG subclasses? And then finally, if you're concerned about phagocytosis, are the neutrophils and macrophages working? Then you can do a neutrophil burst test. And you have to send some of your own blood to the lab when you send the child's blood for the neutrophil burst test. If it doesn't go smoothly and you send it at the wrong time and you have to curry a few samples, you will end up with an arm full of holes like I did with this one. So, his immune screen, the most important test, the full blood count, showed a lymphocyte count of 0.1, and his PCR on an NPA was positive for pneumocystis jirovecii. So he had PCP pneumonia, and his diagnosis turned out to be ADA SCID. So moving on to sort of the second half of this, which is really now I've shown you what are the common things that will cause repeated episodes of coughing and being unwell, and then how to tease out stories of where you've got something like persistent bacterial bronchitis versus a much different story where you've got a higher risk for an immune problem and the immune screen picks it up for you. Thinking about respiratory presentations of immune disorders, the lungs are in the front line, okay? I believe that's in the news. And so immune disorders will often have respiratory presentations, and respiratory teams will help to pick up or help to diagnose things like severe combined immune deficiency, SCID, common variable immune deficiency, hyper IgE syndrome, which you'll know as Job syndrome, or chronic granulomatous disease. So I'll go through them in the time I have left until Atul starts looking nervous. So SCID, it's an umbrella term. It's a group of inherited disorders, and you end up having non-functioning lymphocytes, T cells, and then a mixture of B cells working or not, or NK cells working or not. It tends to present around 3 to 6 months of age as the maternal antibody wanes. So the child, the example I've given you, presented with their bronchiolitis about 4.5 months old, and when they hadn't got out of oxygen, came across to us. You have to remember that can be earlier in ex-premature babies, because as the placental antibody crosses mainly in the 3rd trimester, if the child's missed out that 3rd trimester, they'll miss out on that antibody. And there may be a family history. So pushing on to the fact that the history is always key, the child I've told you about there in that episode, we went back to the family, we said, look, we think there is an immune problem here. We're going to have to send you across to the immunology team. And they said, oh yeah, you had a cousin who had something similar and you had to go to Great Ormond Street for the immunology team and had antibiotics and lots of tests. Could it be that? Always take the history properly. Go further than just who lives in your house. So then symptoms and signs for SCID. Children have a persistent cough, and that can be due to pneumocystis or it could be due to CMV. It may present as a failure to clear colds or a limited response to repeated courses of antibiotics. They can have other symptoms beyond coughs and lung disease. Obviously, they will have rashes. It's quite common to have persistent diarrhea if they're infected by Cryptosporidium, rotavirus, adenovirus, and they may present with failure to thrive. The classic example of severe combined immunodeficiency is David Vetter, with the boy in the bubble, if there's any Paul Simon fans left out there. Now, he was born, I read about him last night on Wikipedia. It's quite a sad tale. It's not the best thing to read just before you go to bed. But he had an older brother who was diagnosed with SCID and died. His family had an X-linked version, and the family were told that if you had any more boys, they'd have a 50% chance of having SCID. He had an older sister who was well, and then when he was born, just in case, he was delivered directly from uterus into this plastic, essentially cell that had been built in Texas Children's Hospital in Houston. He lived in, essentially, this plastic bubble. NASA made him a spacesuit, which is the normal picture you see of him is he's behind this this plastic wall. So I thought I'd show you the spacesuit picture that they made for him, which allowed him to get out and about. But he ended up dying, unfortunately, of a EBV infection after getting a bone marrow transplant from his sister. They had tested her for EBV and it wasn't positive on the assay, but he ended up essentially dying of Burkitt's lymphoma after BMT age 12. So if you think you've got a child with SCID, you call immunology early, let them know, and they will tell you the test to do. They're often going to ask you to start cotrimoxazole just in case. No live vaccines. And then they might get you to send a PHA, as I mentioned. Now, the no live vaccine things is interesting because there are now some DNA diagnoses for SCID that can be done on newborn screening. And there's a pilot study for newborn screening for SCID going to start in the UK in a couple of sites, hopefully later this year. And the debate around getting that done has been you didn't want to start giving children the BCG vaccine if you knew somewhere that somebody had SCID as a result in a laboratory somewhere, which is probably why there's been a bit of a delay with it. Moving on, common variable. It's a group of disorders characterized by decreased production of immunoglobulin, predominantly IgG. It's a rule-out diagnosis, so you've got to be sure that there's no hypogammaglobulinemia for any other reason, and it's super rare, about 1 in 50,000 people. Usually, will get picked up in primary school age, but maybe late teenage, early adults, and they get recurrent bacterial infections because they can't opsonize the bacteria because they haven't got the antibody there. So they get otitis media, sinusitis, and endobronchial infection, typically with strep epinephilus. This girl here on the right is a snapshot from the internet of a story, I think again from an American hospital, where they're miserable, they're unhappy, and it takes a long time for these children to get picked up because it's a difficult diagnosis to make because you've got to exclude lots of stuff and you've got to think about it in the first place. So the average diagnosis takes 2.5 years, and then IVIG treatment is transformative, and at the bottom it's the same girl on IVIG infusions as opposed to previously where she's in a grump. And on top of the IVIG, you need to do aggressive organism-specific antibiotics. Okay, rattling through now with my 5 minutes to go before questions. Damien Rowland yesterday did an excellent talk about using the internet to find out information, how the youth of today are Googling, using YouTube directly rather than on Google. I thought I'm the youth of today, I'll have a bit of this. So this is a screenshot of YouTube when you put in hyper IgE syndrome, and it does give you some really good characteristic pictures. This is the original report in the Lancet from the 1960s, where Job syndrome is first described. Job was tested, his faith was tested by having recurrent boils and abscesses, which is where the name of the syndrome comes from. And these children present early in life with rashes as babies. They have recurrent eczema, abscesses, lower respiratory tract infections, eosinophilia, and the serum IgE may be raised, but in about a fifth of cases, it's not up. Again, the majority have got a STAT3 mutation. Some of them are de novo and some are autosomal dominantly inherited. And the STAT3 is really important in Th17 signaling, so that drives inflammatory responses. So if your Th17 isn't working, then you have difficulty fighting off things like Staph aureus. So children get rashes in the first few weeks of life and recurrent boils. respiratory infection, and recurrent respiratory infection can lead to bronchiectasis and pneumatoceles, which can then secondarily get infected by things like Aspergillus and Pseudomonas. There's a very nice review on hyper-IgE syndromes here at the bottom. And they may not present with fever because they can't do the cytokine signaling. So you know, if you get your cytokine switched on and develop a fever, then somebody's knowing that you're unwell. But these kids may not do that. So you need very low thresholds for chest imaging and antibiotics, as well as prophylaxis and skin washes. There are some other signs: retained primary teeth, characteristic face, I've shown you in the Lancet article. And it's quite a variable syndrome, and as the immunologists and allergy doctors work into it further, they're picking up other genes that are associated or give very similar phenotypes. And I've got a list for you here at the bottom, DOC8 being the most common one. Okay, finally, searching on the internet again, on YouTube, chronic granulomatous disease. Neutrophils and the monocyte macrophages have got to do phagocytosis, and if they can't make bleach, then they can't kill bugs. So this is a phagosome that you can see here on YouTube on the inside of a cell, and the NADPH enzyme is part of the subunit that sits on the outside of the phagosome and will donate an electron that will meet oxygen inside the phagosome. If you go to YouTube, you can watch the whole video. And that will react with oxygen to form superoxide, react with water to form H2O2, hydrogen peroxide, bleach, and then that is directed amongst other things to make the bacteria inside the phagosome lyse and they're destroyed. Now, if you can't get the NADPH to work, you can't get the oxygen in, that impairs your oxidative burst, so then the immune cells struggle to clear catalase-positive bacteria. Catalase, of course, the enzyme that breaks down hydrogen peroxide that we all did at school. And what you end up with is infections and large numbers of neutrophils and macrophages getting called in to try and smash up the stuff that's there, but they're not working. And this large mass of non-functioning macrophages and the occasional neutrophil is called a granuloma. More common in boys, approximately 2/3 X-linked. And you typically get these granulomas in sites where infection gets into the body, so skin, lungs, and then tracks the lymph nodes. Aspergillus and mycobacteria, as well as Staph aureus and nocardia. And similarly to common variable, these children need cotrimoxazole and then some azole antifungal prophylaxis, early aggressive treatment of infections, and then bone marrow transplant can be curative, and gene therapy is in trials. So that is going on at the moment in Boston, although mind you, it might be on board. So to finish off, what we talked about is really some thresholds at which you need to be thinking this could be that one rare one who's come through my clinic who might well have an immune deficiency going on. We talked about the numbers of events of infections, or the time courses of infections and durations of defections, as well as the red flags that are important to consider. I've gone through what an immune screen means in terms of my understanding of the basic physiology and immunology and immunopathology, because then I've got a scaffold to hang it on. We've talked a bit about some of the conditions you may help to diagnose, or you might be the first person to pick up, and then the management of these alongside your immunology colleagues in the respiratory clinic. Thank you very much. Atul, you're on mute, by the way.
Thanks, Rossa. Excellent talk and overview. Perhaps I think we need to put the comedy for the next year then.
Yeah. It's easier face to face, man.
Yeah. That's what I thought. Thank you very much. So I've got a few interesting questions. The first one from Adam. We hear about investigating for immune deficiency when there is a serious, persistent, or unusual or recurrent respiratory infection. What would be an example of an unusual respiratory infection?
So I would consider that in two ways. The slide I had that talks about picking up bacteria that you're not expecting to find. So a child who comes in, you're not that worried about, but you do some tests and you find they've got Pseudomonas or they're cough-sore, for example. That's a funny one. And then my other definition of an unusual respiratory infection is when 4 doctors in a room all go, yeah. And that would be, one of my major learning points being a relatively new consultant, is to discuss that kind of stuff with your peers. And, if you can say to a family, this sounds a little bit unusual, I'm going to discuss it with some of my colleagues and get back to you. I think that's a sensible approach, and just use the hive mind.
Thanks, Rossa. The next one, and just be aware that some of the audience may be from outside the UK. I was wondering if you count HIV screening as a part of your immune workup.
Okay, so in the UK, all mothers are tested for HIV during pregnancy, or certainly it's offered to them. We tend to know children's HIV status. Yeah, it's a good point, and I should have flagged it up, especially for people coming in from outside the UK or people who may have declined screening. So yeah, that would be a basic part of an immune workup as well. Absolutely.
Yeah. 2 questions. IgG subclass, when should you do it and how useful they are?
Yeah, tricky. I think if we knew, then we wouldn't get questions like this, and I wouldn't have tried to slightly gloss over in the talk. So I'm sure lots of you are aware that it can change as a pattern of maturity, and your IgG subclasses will catch up as you get older. I think what tends to happen, what I see people do in the practice I have aped, has been that if the IgG subclasses are low and you don't have anything else that's going on and the child is unwell and you repeat them and there's still difficulty, then I think that's reasonable to send them to an immunologist to say, do you think there's a problem here? But I think time is a useful investigation there unless the child's very sick.
Thank you, Rossa. Another common problem we see is IgA deficiency and those people who have got sinopulmonary infection. So apart from giving antibiotics, what else can we offer to this group?
So in that group, yeah, and that can be really difficult. I think we possibly underuse things like sinus washes. I try to use it more and more in the cystic fibrosis population, but it's not a popular thing to do, and it's not a nice thing to do. I would think I would struggle to get my child to do a sinus wash every morning as a prophylaxis measure. But apart from either using saline rinses, because you want to live your life. It's not as if you want to stay indoors and try and dodge getting infections from going to school and this kind of thing. So the sinus washes and antibiotics, I think, are really the mainstay for it.
Thank you. Another very important practical question from Amanda Equi. What is the most efficient use of resources in the DGH? Should they be doing sweat test, IgG, immunoglobulins, vaccine antibodies, MBL, and full blood count? And do you think this is sufficient before they make a tertiary referral? So sweat test, immunoglobulins, vaccine antibodies, MBL, full blood count.
Yeah, that sounds absolutely fine. Yeah, I don't think you would want to do much more. That's essentially what we would do in the clinic anyhow, the tertiary level to start with. So if you get a referral that all done, then that certainly helps you sort of narrow down things you're looking at.
Yeah. A few questions about persistent bacterial bronchitis, or protected bacterial bronchitis, which antibiotics would you use? How long would you use it for?
So I personally use coamoxiclav, the biggest dose I'm allowed to get away with in the BNF, and I use it for 4 weeks. The ATS does an absolutely excellent patient information sheet on PPB, and I give that out to patients or email it to them after the clinic. And that explains how common it is for it to recur. My suspicion is that if you've done 2 weeks and it comes back, you may not have done enough. I don't see a huge harm unless there's lots of gastrointestinal side effects from doing 4 weeks of coamoxiclav. And that's sort of the dogma that I've picked up along the way.
Thank you very much, Rossa. There's still a few questions, and perhaps people can email you or tweet you.
Yeah.
Yeah.
I'm not choosy on followers. Thanks, Atul.
Thanks, Rossa. Thank you for an excellent